It really is an honor to be here today to moderate this panel on providing children's mental health services in schools. I can honestly say that I've had the pleasure of working with each and every one of our panelists over the last 20 years, and I can't thank the Planning Committee enough for picking such an amazing group of individuals. You could not have picked a group of people who have more breadth and depth around school mental health and have just incredible knowledge and wisdom related to how to make school mental health work. My plan for today is I will provide a brief context for the panel, and then I will ask each of our panelists one question related to the area of expertise, and then our goal is to turn this panel over to you and to make sure we answer all of the questions that you have. So what do we know? In a given classroom, 1 in 5 students will experience a mental health problem involving mild impairment. 1 in 10 will experience a mental health problem involving severe impairment. However, the majority of these students will never receive any mental health services, and if they do receive services, often they might not be of high quality, and they may only go one time. Of those who do receive mental health services, over 75% of students receive those services within the school setting. We've come a long way in the last 20 years. When we first started in school mental health and had our national center, the idea of providing mental health in schools and providing that full continuum, having family school community partnerships, was pretty innovative. At this point, I would say it's fairly accepted that we need to provide mental health services in schools. But with that acceptance, we've now reached a new level where we need to figure out what is the workforce development related to providing service in school, mental health services. What needs to happen at the pre-service level, at the in-service level? What training and implementation support is needed to implement evidence-based practices and programs? We talk about having a full continuum of services. How do we make sure we have a full continuum of funding sources that are able to help support each of those components on a public health triangle? We also need to make sure that we have evidence-based practices and programs that fit the populations that we're working with that are developmentally, culturally sensitive, and we also need to show that it works. If we're going to be providing services in schools, we need to show that we're having an impact not just on mental health, but also an educational impact. When we're working in schools, we need to contribute to student success. The work that I have been involved in since 1995 in school mental health has been through the Center for School Mental Health, which is the only federally funded center. We're funded by HRSA, and our goal is to strengthen the policies and programs in school mental health to improve learning and promote success for America's youth. We work across research, training, policy, and practice to advance mental health in schools. In terms of the work that we do, we're very grounded in a family school community approach. It's very important to involve our families and communities. We know when families are involved, children do better, and we need to make sure that we are involving families in a meaningful way and not just in a token way. In terms of the work that we do at the center, we are very committed and also aware of the budgets or lack thereof that people have for accessing resources. So everything that we have at our center is practical, free, user-friendly, and we make it very readily available. Some examples of some of the resources that we've developed is we have a document called The Impact of School Mental Health, which really summarizes the research in the field. We have a monograph that we have been working on with the PBIS National TA Center and the IDA partnership of how to embed school mental health into positive behavior interventions and support. So really taking the mental health and education systems to create one larger infrastructure. And all of our materials you can find on our website, which is listed here. As well, we have other websites that we're involved in, www.sharedwork.org, which we have a national community and practice on collaborative school behavioral health, which works across states, national organizations, and different practice groups to make sure that we are continuing learning related to school mental health throughout the year. Our center I'm one of two co-directors. My co-director is Dr. Sharon Stephen, and we are incredibly committed to working with all of you and are always open to questions and ideas for additional resources we can develop. Before we turn to the panel, I just want to make sure that we're all on the same page with what is meant by comprehensive school mental health. When we talk about comprehensive school mental health, we're talking about a partnership between schools, communities, mental health, and health organizations as guided by youth and families. We need to build on existing programs and services, so this should not be starting from scratch. What do you have? How do we build from that? And we also need to make sure that we're filling in, we consider the needs of a given community and we're addressing the gaps that program may have. I do just want to say, we're talking about what school mental health is. I just want to briefly mention what it is not. And this is like one of my pet peeves here. But often people go into schools because it's a convenient place to see kids, and they may set up shop, but they're not really integrating with what's going on in the schools. When we're talking about comprehensive school mental health, we're really talking about that integration, the integration and collaboration. Without that, you're getting mental health services. It happens to be in a school building, but that's a whole different story. So very quickly, when school mental health is done well, we have, what we would see is, we would see this triangle, the public health triangle, and we would be providing services in collaboration with the education systems across the 3 different levels, from universal to selected to indicated, so for all youth, for youth at risk, and for youth with the highest needs. What we would see when this is done well is you'll have improved access to care, you have improved academic success. We also have cost savings, not only related to mental health, but also related to education. When you can help students be more successful, often they don't need more costly, more restrictive placements. And we also would see improved social-emotional behavioral functioning. Now with that, I'm going to finish here, and I'm going to turn things over to Joyce and ask her to comment on the federal perspective of school mental health and some of the great work that's being done.
Thanks, Nancy, and I do want to extend my appreciation on behalf of SAMHSA for this wonderful day and the great opportunity it's provided to focus on children's mental health, and particularly on school mental health as I am here. It's a very important topic, and our nation's future is at stake. So we greatly appreciate this opportunity. So I wanted to talk a little bit about SAMHSA's initiatives around children's mental health and some of the cross-federal partnerships. I want to talk a little bit about the Now is the Time, which Paulo referenced this morning in his plenary session, and just provide a little bit additional information. And I also want to provide you with some resources that will help you be more in touch with some of the initiatives that SAMHSA is doing in terms of children's mental health and school mental health in particular. So just a little bit about SAMHSA. Just a quick show of hands. How many have know about SAMHSA? Most people do. Yeah, so some maybe not as much. But SAMHSA, as Paulo said, the mission is to reduce the impact of substance abuse and mental illness on America's communities. So that's pretty all-encompassing. And the way SAMHSA has organized that is through 8 strategic initiatives. Some of them focus on improving overall behavioral health in the nation. Some of them focus on transforming the care system in America, and some are focused on our internal excellence in terms of operations. But the number one strategic initiative is prevention, and prevention of substance abuse and mental illness. That means creating communities where individuals, families, schools, faith-based organizations, workplaces take action to promote mental, emotional, and behavioral well-being and reduce substance abuse, including tobacco and suicide. So we focus a lot on high-risk populations and youth in tribal communities and military families in particular. We have a missed opportunity every day in terms of the opportunity to address these important issues. And when you look at some of the data from SAMHSA, Center for Disease Control, we see that mental illness is one of those areas that's most costly when you look across other illnesses such as diabetes, heart disease, hypertension. That both the cost is extremely high and higher than many of those other chronic diseases, as well as the percent who receive services is much lower at about 37%. So we have our work cut out, and we need to raise public awareness. A lot of the conversation today has been about how do we change that conversation in terms of stigma, but other ways that we think about mental illness, and I want to talk a little bit about that. Again, when we think about a future that's prevention-focused, what might we think about? What might that look like? Does it mean that families and children have access to all the best available evidence-based preventive interventions? And when I say interventions, thinking both about clinical and more medically focused interventions, but also community and environmental interventions that are delivered in culturally competent and in respectful ways. Preventive interventions are provided as a routine component of school, health, and community service systems, that children and families have multiple points of entry, and that we're not just thinking services, but we're also thinking about supports and formal and informal kinds of supports that help young children thrive, and that environments where children live, learn, work, and play and worship are safe, healthy, and nurturing environments for young people and their families. So this requires a real shift in how we think about mental health. Beyond the one child at a time approach, we need to be thinking about populations and how we can impact populations. We've touched on this a little bit today, just in terms of we know that there are populations that are at higher risk, where there's disproportionate rates of mental illness and substance use. We need to be thinking about populations that have higher rates of trauma and other exposure to violence that leads to many of the conditions that we're concerned about. And we need to be informed by the growing body of prevention science, which is one of the areas that SAMHSA's focused on in terms of there's still a popular understanding or belief that there's not much you can do to prevent mental illness and substance use. And we're learning that there's a tremendous amount that we can do and we need to do, and we need the public will to make that happen. We also need to build our public health infrastructure for mental health and behavioral health and include that shift to thinking about wellness, not just illness. We need epidemiological data on the prevalence. We don't have those systems in place. They're very extensively. They're beginning to be built in states, but we need to do a lot more, and we need to be thinking about what that capacity is, what it looks like, and how we can really grow it and make it meaningful to inform policy and practice. In a capsule, a lot of the belief around services and environments has to do with we need to understand that medical services, while we do need to do all the work that we've been talking about, but it is not the primary determinant of health, and we're beginning to get a much better understanding of how social determinants of health impact health, and we need to be looking at. One study showed that only about 40% of health outcomes, or about 40% of health outcomes are attributed to social and behavioral health factors. So we mentioned, I don't want to forget to just mention, I won't go through all the details, but if you want some slides that I'm referencing here, there are cost implications to all these things. You know, preventing a child from becoming dependent on alcohol is about $700,000 a year, high school graduation, and preventing them from being dropout, cost savings around that. So I won't go through each one of those, but they're significant and important. So the Institute of Medicine report that Paulo mentioned was developed in 2009, focusing on preventing mental, emotional, behavioral health disorders in young people. And this is a policy document for SAMHSA, really. A lot of our work is being guided by this Institute of Medicine report. If you're not familiar with it, get out there, get it. You can download it online for free, and also it's available for purchase. What we know in a nutshell is that well-designed prevention interventions really work. Prevention and wellness interventions can have multiple benefits beyond a single disorder. And states are beginning to really focus on that looking at if you know about risk and protective factors, you know about prevention science, you can design interventions that are going to reduce not only mental illness and substance use, but also teen pregnancy and youth violence and other kinds of things. So it's an exponential effect there. And that the key is to identify what those child's risk and protective factors and then do your planning and intervention in relation to that. Some core concepts of prevention, again, the paradigm shift. We need to be thinking of mental health as part of overall health. Successful prevention is inherently intervention. Interdisciplinary. One of my colleagues says we need to give mental health away. And whatever language people use, whether it's education or child welfare, we might use different, and families might use different language. We need to not be stuck on talking about our mental health language. We need to be talking about children's well-being and development and whatever language translating it so that we get things done. We need to be thinking developmentally because interventions vary depending on the age of the child, and we need to be coordinated, as Nancy said, across multiple systems and working in partnership as we give it away and have others own it. SAMHSA has organized some of its programming based on the developmental phases. So I'm going to talk a little bit about some of SAMHSA's programs and how we've organized those. But specifically, and the IOM talked about this, that you may have home visiting programs for new moms. That's important. You may have school-based mental health for school-age kids, mental health consultation in early childhood settings. Different kinds of strategies work for different age levels. One size does not fit all, and the earlier the better, but also there's a window of opportunity that the Institute of Medicine report also highlighted, where you start to see signs and symptoms around 2 years before, on average, many of the illnesses, and so these are really critical periods of time to step in and be ready to move. And then we've talked a little bit about trauma. SAMHSA has the National Child Traumatic Stress Network. We're learning so much more about the role trauma has in terms of these interventions, and it's exciting to see that states and communities and nationally we're beginning to have some ways of identifying and track trauma. These ACEs is called the Adverse Childhood Study. States are beginning to do these studies in their own states, so you can look from a public health perspective and say, this community has very high numbers of ACEs. This community is less. You design public health interventions that are really strategic and targeted based upon what those are. And the more ACEs that someone has, the studies are also showing, if you look at, there's a great infographic on the CDC website that just maps out if you have 1, 2, 3, or 4, and what the likely kinds of behavioral impacts it may have. So it's not just about the goldfish, but also about the water. Someone said that, and I love that quote, so we need to be thinking about both. In a quick overview of some of SAMHSA's programs, I sit in the mental health promotion branch, which is part of the division that covers suicide prevention, the National Child Traumatic Stress Initiative. We partner a lot. Lisa's going to be speaking this after this panel with Systems of Care, which is in this Center for Mental Health Services, which we're both part of. Some of our grant programs include the Safe Schools, Healthy Students program, which has been mentioned this morning, and I'll talk a little bit more about that later. We have now a 2.0 version of that. Project Launch, which is for birth to 8. Prevention practices in schools, a very innovative program started by a first grade teacher in I believe it was Kansas, and now it's almost going viral nationally, but we do have a grant program that has been very well received, and one of those things where those in education know that teachers are often resistant when you come in with a new program. Well, this one is one that they beg for when you come down the hall, and they say, how can you see such impact in a short period of time, within weeks, that children's behavior is impacted and changed for the better, and we see results along those lines. And then the other ones I want to highlight, which are national initiatives, the National Forum on Youth Violence, Strong Cities, Strong Communities. We've done state policy academies focusing on prevention, as well as many other topics, and stopbullying.gov, which is about my time? Yeah, so those are some of the highlights of the various programs, and we can talk more about those. Just I want to say the 2.0 version of Safe Schools is one that's now going to states, and so it's instead of communities, which we've done before, now it's going to states with community partnerships. Okay?
Thank you, Joyce. I'm going to turn things over to Olga Acosta Price, and Olga, I'd like you to comment on your perspectives on school mental health at the national and state level as it relates to financing and sustainability, which is probably one of our greatest challenges in the field.
Absolutely, thank you. And thank you for having me, and Charles for inviting me. I'm sort of an eternal optimist, so I always like to start with the good news. We have a lot to celebrate. Thank you. With regard to the advancements in our knowledge, and also, as Joyce was saying, in the commitments that are being made at various levels, at the federal and national levels, with regard to interventions that we know help us deliver high-quality care in partnership with schools. There really is a lot for us to feel very good about, and you're going to hear, I think, much more from my colleagues after I speak along those lines. You know, these advancements include better implementation methods of effective prevention programs, as Joyce was mentioning, these comprehensive integrated services, and evidence-based practices that reduce risks, prevent problems, treat conditions using what we might call a place-based strategy. It's no longer sufficient, though, I would argue, that we need to implement effective programs. At one point, part of our, I think, role was to try to convince communities and administrators and others that using an evidence-based program was not going to be terrible. It wasn't going to, suck up all of your resources, and it wasn't going to be too difficult to implement. I think we've actually, in many ways, won that battle. But I think the next one is that we have to be just as passionate about making the case that these effective programs have to be sustained, because what we're learning is that being effective does not ensure that these programs are going to remain in communities. So what continues to be lacking, both in terms of practice and policy, are these comprehensive strategies for sustaining school-connected mental health programs that we know are effective. For many school community partnerships across the country, keeping programs going long-term, what that often means is you're looking for the next grant opportunity, right? You're writing the next grant. That's often what we do. And this is a necessary part of the solution that we really should try to facilitate, and I think our policies hopefully will help us do that. But it really is an insufficient strategy given our current state and federal economic condition, essentially, and that paragraph with 3 words, there's no new money. So we have to be innovative and creative in thinking about how we are going to keep these effective programs going. 2 resources that I wanted to bring to your attention, and I did bring copies of these. They're out on the table. I really encourage you to take some back for your colleagues, that we've developed to help us better understand the financing landscape and to highlight emerging successes. I really feel that that's also really important, and something that I think SAMHSA and our other national partners have tried to do, which is to help us learn from other communities and other states that have really broken ground and moved moved forward. So I guess part of what I think it's underscored by the comments just made about the importance of mobilizing, and certainly mobilizing at the federal level, but the importance of also mobilizing at state and community levels, and what we need to do and how we can effectively do that is what I hope to just share a few points about today. In the state work that we did, we interviewed people, 47 people across 11 states, and we really wanted to try to understand some of the common issues, some of the opportunities for strengthening children's mental health service systems. What we really found is that in most states, we continue to have a dominant illness focus for the traditional system of care models. And these are agencies, these public mental health agencies, where I have been and have had the pleasure of having part of my career. They don't and often can't really be the single agency to promote wellness and health as it relates to behavioral health. Because in many cases, the financial and political pressures that they are undergoing often pits prevention and treatment, and they're competing for money and attention. And that's some of the political reality that we have to recognize where negotiations and challenges occur. The officials that we spoke to, again, at the state level, said that even despite their good intentions and their sincere desire to do differently, the limited funds and resources available in many of their states and communities had to be directed to those who were seriously mentally ill, and they should be. Because it's central to their mission often in the construction of what these agencies are intended to do and to oversee and enforce. But leaving mental health prevention and behavioral health prevention to public mental health agencies can be a problematic recipe for success. The third case, this case study, that is also featured here, again, that we have outside, has us realize that even though we have a lot of challenges as it relates to how we fund prevention, we know the prevention science has really advanced our understanding of how much we can impact long-term suffering and reduce and change those negative trajectories for many kids and families. Funding remains a very significant issue as it relates to prevention and early intervention. But even for treatment services, where we should have the kinds of funding streams and the mechanisms available to offset the costs and for those expenditures, for school mental health in many places that continues to be a challenge. We were able to feature 3 communities, including Washington, D.C., where they really were able to help us understand and explain how they could access Medicaid funding, for example, for school-based services through local partnerships. And it was really critical that we tried to sort of, again, practically understand how they made that progress. Both reports, importantly for us, share bright spots, successful examples where collaboration, advocacy, and these cross-sector partnerships that included mental health, public health, and education at a minimum resulted in these incremental improvements in children's mental health. I just want to share some lessons learned from some of this work as well as our previous work in the development of school-connected programs, and what we think are some of the key factors contributing to sustainable approaches. One is business planning and financial strategies. We know that explicit plans and strategies are needed to sustain programmatic advancements, and they have to include deeper commitment to planning, to identifying the right partners in communities, and to paying attention to outcomes, which I think my colleagues are going to talk about, that start even before an initiative is really implemented. Developing business plans and sound financial strategies, knowing if you want to deliver a full continuum of services, that you have to think about the fact that the funding streams for each of those categories of care or supports may have to come from different places, different parts of government, and may require a different set of strategies for you. But these are often an afterthought, many times not even on the radar for most providers. More commonplace is that what we have to make more commonplace is that the interventions that we want to offer, that we map those against what we know is occurring in our communities. Let me run through these kind of quickly. We know that health and education reforms abound. I think this can be good. It creates opportunities that we should be taking advantage of. For example, we know that in Massachusetts, they were able to expand their children's access to mental health screening through statewide reform efforts. And Minnesota is another state that, with state and county officials, had worked together with insurance providers and managed care companies, and they were able to successfully expand services, often non-traditional services, that could be eligible and paid for by reimbursement through their state Medicaid plan. So are school mental health programs and services being discussed? Are they a part of the discussion while essential health benefits are being determined, while accountable care organizations are being developed, and while exchanges are being created? Are you, as advocates for this care and this category of care, at the table? We also have to remember the value of public-private partnerships. No one sector can do it alone. We really do recognize that, I think, both nationally and locally. Advocates, for example, in North Carolina is an example of a partnership between mental health providers such as those of us here, the American Academy of Pediatrics, and professional organizations that at the state, again, were able to expand who the eligible Medicaid providers were who could screen for mental health problems, and they also were able to successfully increase the number of visits that could be paid for without a diagnosis. Again, that happened because of the partnerships and who they were able to influence. Also think about the partnerships with private philanthropies and the role that they can play in supporting the aspects of sustainability. For example, New Hampshire, the state of New Hampshire, the New Hampshire Charitable Foundation and the Endowment for Health were able to fund the important preliminary work that was necessary to create a statewide collaborative network that led to the successful award of the state for behavioral health systems of care, including their first Safe Schools, Healthy Students grant. Again, that was, I think, a direct result of this ability to come together as a state. The funding innovations that we do know about, we're still learning about some of them. We do know about, for example, local levies that have been used to fund some services, again, that you may not have access to through traditional mechanisms. Also newer models like social impact bonds that cities and states are still experimenting with. And so we still need to know more about them, but they're very innovative, and these financing strategies are ones we should be keeping our eyes on and learning about. I guess one of my last points is about aligning these strategies, which Nancy had mentioned. Often if a state doesn't know about the local effort, they are not likely to going to want to partner to sustain it long term. And we've learned some painful lessons from previous discretionary grant programs and how they were structured that have taught us that we really need to hook to these broad state initiatives. And that's now been corrected. And with new programs on board, we really have been taking advantage of the fact of the resources and the knowledge and the commitments that come from states, and then the expertise and the skills and the knowledge of communities that come from our local partners. Again, across sectors, education, juvenile justice, child welfare, health, these alignment and integration have led to cost savings, to better use of dollars, and to longer-term impact. So I guess institutionalization, I would say, is one of the keys to sustainability. What I would ask all of us to think about, what are those federal, state, and local policies? What are those organizational structures? What are those advocacy pathways that are needed to create this shift from a sole focus on treatment to this full continuum of care that Nancy has talked to us about? Together, we can strengthen our approaches to better serve children and their families, but we have to assess how our health and education policies, practices, and funding streams can be better integrated to improve the odds for achieving positive health for kids and families. Thanks.
Thank you, Olga. I'm going to now turn things over to Michael Lindsay, who'll spend a few minutes talking about school mental health related to the research work that he's been doing.
Good afternoon, and thank you for having me. Thank you, Charles, for inviting me as well. So I'm going to talk about evidence-based practice in terms of the promise that it holds for really addressing mental health issues in schools. And I think evidence-based practice represents the need to do what works, and certainly across a number of diagnostic categories, we know what works in terms of addressing disorders. And I think it's interesting, I have here depression as an example of sort of how best practices can address an issue like depression. What we know about depression is that it's one of the most undertreated mental health issues that children and adolescents present with. It impacts about 8 to 11% of youth in the U.S., but only 30% of youth who have depression actually receive treatment. We also know that the consequences of untreated depression have severe public health implications in terms of substance abuse, early sexual experimentation, school dropout, and certainly suicide. And so I think that it really represents an opportunity for us. What I've found in my work, and I'm giving you a view from the front lines as both a practitioner as well as a researcher that's implementing evidence-based interventions in schools, what we find is that for an issue like depression, it really doesn't come to the attention of school personnel, school mental health professionals, because these are not the kids that are bouncing off walls. These are not the kids who are getting into fights and really exhibiting externalizing behavioral problems. So, you know, evidence-based practices with a specific target on depression as a focus of treatment can actually reach those kids who are suffering from depression and in need of services. Schools represent an ideal setting to address depression at all levels. So Nancy mentioned the public health perspective in terms of school mental health intervention. So at the indicated level, those are kids who are exhibiting depressive disorders or who are suicidal, and certainly there are evidence-based practices that address depression at that level. At the targeted level, we're talking about prevention programs, and certainly we need to, as Olga mentioned, address more of our efforts toward prevention of issues like the symptoms of depression before they become more serious. And I think it has, there's a lot of promise at the universal level. Certainly there are evidence-based interventions that focus on each of these levels, but at the universal level, there's a lot of promise for making the treatment of depression, or at least the content around how best to strategize and address depression, as part of the school curriculum. So imagine then that teachers or principals had the language and the skills to be able to address depression at the global level, to talk about symptoms in a way that really helps to usher in that perspective in a non-stigmatizing way. And so there's promise even at the universal level. But what we find is that there are many challenges to overcome, and certainly we're addressing these challenges, but they're challenges at two levels. There are the school level challenges or issues and treatment level issues. So what we find at the school level, particularly working in an urban district like we are in Baltimore City, is that there's a lot of fluid change in terms of leadership. There's often a lot of struggle around disciplinary silos and turf issues in terms of who's going to treat mental health issues, limited staff and resources, as well as bureaucracy in terms of the various funding challenges that we experience in terms of support of our services. And so these school level issues certainly impact the implementation of evidence-based practices, and certainly things that we have to counter in terms of our preparation to deliver those evidence-based practices. And I think at the treatment level, we're talking about issues of training, coaching, and supervision. So making sure that the evidence-based practices are delivered with the intent that they were originally designed to be delivered. So making sure that supervision is in place, there's efficacy or fidelity to the model in terms of the interventions. Support for sustainability. And, you know, I think the question for me is, can non-university personnel be trained to deliver interventions with equal success? I think it's a challenge that we face in terms of developing these evidence-based practices, but ensuring that they're sustainable and will remain once the funding to support the research around these evidence-based practices is no longer there. Family engagement is certainly an issue, and I'll talk about that with greater detail. So what we know is that schools provide great access, obviously, to kids who are exhibiting mental health issues, but what I found in my work is that perceptual barriers still prevail. So while we have access to kids, it doesn't necessarily mean that they're beating the door down to run to our services, or their families are going to be supportive of the services that we provide. So I think then that in schools, engagement interventions can lead to stronger treatment connections and outcomes, theoretically. And I say theoretically because I think we still need to, have engagement interventions that are developed that can be done in schools. We've certainly seen a lot of success in community-based treatment, but can we do this successfully in school by engaging both the children and adolescents as well as their parents or caregivers? And I think sample strategies include like psychoeducation about services and motivation enhancement. And I'll end with a quick anecdote. So we're delivering an evidence-based intervention in Baltimore City schools for depression. And we came to this young lady, we came to our attention, who was suicidal and very depressed. And so we contacted her mom, and her mom wouldn't come to school to sign off for services or consent to treatment. And so eventually, through our engagement efforts, mom did show up. And so one of the things that mom said was, I was afraid to come to the school because I thought you all were going to blame me for my daughter's depression. And when I worked with the clinician, it was quite the contrary. So this is an example of how psychoeducation about services and the ways that we try to normalize experiences for families can really help to connect them to treatment in a positive way. So that was a success story because the young lady ended up having a successful treatment, and the mother was, really thankful for that in the end. So, while we have these evidence-based practices, we still need to kind of focus on these issues, and I'll stop at this point.
And now I'm going to turn things to Barbara Parks to really provide us with that local perspective. Where does school mental health fit in, and what do you think our policymakers need to know at the local level?
Thank you, Nancy, and thank you, Charles, for inviting me. I am Barbara Parks. I work for the D.C. Department of Behavioral Health, and it's really my pleasure to talk to you today about my favorite subject, which is school mental health, and to give you a perspective from the local side. I always start with some type of a cartoon or something to kind of illustrate really kind of what our students are facing today, and the intersection, I think, between the educational system and mental health. And I think it's been mentioned by the panelists and several people today that really it is a true integration. It's not just placing mental health people in the back hallway and seeing them for treatment. We want to be fully engaged and also understand the connection to learning, which I think is becoming more and more critical as we are being asked to be in schools, so that we look at schools as our partner. Oops, sorry, going too fast here. Oh, wait a minute. These are a little out of order. Sorry. Oops. Okay. I'm missing a slide. That's okay. So let me tell you a little bit about our program. And we actually started in 2000 with a Safe Schools, Healthy Students grants from SAMHSA, as we've been talking about sustainability and funding. And we started off in 17 charter schools and have grown today to 52 schools. We went through a rather large expansion in 2006, and we're actually very fortunate to be receiving additional funding from our local government to expand into 19 more schools this year. So we should be in 71 schools before the end of the school year. We do follow a public health model. We do universal, we do early intervention, and also treatment services. And our model has always been to provide an individualized plan for schools. We do a needs assessment at the beginning of the school year with the principal and key staff members to talk about what the needs of each individual school are. But we do provide intervention and services on all the levels. And our model basically is we place a school mental health clinician in the schools either on a full-time or a part-time basis. And how we determine that is basically based on enrollment and some other factors around resources in the school and availability and readiness for school mental health. But as has been discussed today, I think the importance of being able to provide strategies and intervention at all levels. So primary prevention, I think it really can address 80% of the students. And that early intervention piece around 15%, and then the more indicated or treatment level, more the 5% level. We have been providing evidence-based programs at the universal and early intervention levels for years, and we've used registries and have brought in trainings around that. We do sexual abuse prevention, violence prevention, suicide prevention. And we actually have been working very closely right now in DC with several key stakeholders as we are kind of doing a blueprint now to really look at even improving our school mental health system even further here in DC, and really taking a look at more expanding that Tier 1 level of services where we can actually embed social emotional learning into the core curriculum, which is so important that our students are getting that, not just from mental health professionals, but really they're hearing it from the teachers, and it's part of their health. That mental health is just as key. We do provide some crisis services as well, and as Dr. Lindsay talked about the importance of parental and family engagement, working with parents and providing parent workshops. I think, oops, wrong thing. Okay, so this is kind of a busy slide, but what I really want to just illustrate here is that this is 5 years of data. We've actually been around now for 14. But you get a sense of just where we're at in terms of referrals, students on caseloads, and those are formal treatment caseloads where kids are actually open with a treatment plan, diagnostic assessment, the number of sessions we've done in the individual, family, and group therapy, and then the prevention. You'll note 9-10 was a big year for us, but we were also in 59 schools at the time, and we are now in 52, so we did lose a little bit of funding over a period of time there. But we've been pretty consistent, and the model has shifted a little bit. We're still, years ago, we were kind of 30-30, 30-33, 33. We were really pretty even amongst the tiers, but we're doing a little bit more treatment than we were before. And part of that has been a little bit around sustainability as we are using reimbursement for our treatment services that we're providing. So the other thing, and the message I want to leave you with today too, is that school mental health works. And one of the things that we know about school mental health is, and over our years of being sustained as a program, is we've had to show that it works in order to keep it going. And so after a while, it wasn't enough just to say that people liked us and they used us a lot. We needed to show that what we were doing worked. So we've been implementing on the treatment level, the kids who are seeing our clinicians for services, the Ohio Skills instrument now for a number of years. And this is a 40-item questionnaire that measures problem severity and functioning. And we've demonstrated for the past 5 years improvements in these domains. And what this slide is showing is the decrease in problem severity. There are 3 ratings on this. The child, the worker, and the parent fills this out. And it is for kids over the age of 12. This is the functioning scale, so you'll see that functioning improves. So it's kind of going in the directions it's supposed to. Problems go down, functioning goes up. And again, this has been something, this is our data from 11-12. We haven't finished compiling our 12-13 data yet, but hopefully it'll be the same result. And then I want to talk just briefly a little bit about early intervention. We have a program called Primary Project that is a little bit of an offshoot of our school mental health program, which is for mild school adjustment. And it's an evidence-based program that's actually been around since the 1950s. And we started implementing this program about 5 years ago. And it's for pre-K kids up to 3rd grade. And it involves universal screening by teachers. And it's used an instrument called the Teacher-Child Rating Scale. And the teachers screen the children, and the screen will tell us whether a child is just doing fine and doesn't need anything, if they fall into a mild school adjustment issue, or if they're in need of more significant mental health services. We've been doing this for the past 5 years, and we screened a lot of kids last year, and we're really on board to screen a lot more this year. And we've expanded this program. Last year we were in 35 sites, and this year we're going to be in 40. Anyway, you can see it's an interesting in the sense that this past year, we identified so many kids here in the district that were in need of something. And last year was an inverse for us. We actually found more kids who needed mental health services than early intervention, which has not been the way it was trending. It was a bit concerning to us, especially because we were screening younger kids. But I think it highlights the importance of us doing social emotional screening. The primary project works on 4 domains, and I'll show you the results of this. And I'm wrapping up, but so these are the 4 domains: task orientation, how well a child stays on task; behavioral control, assertiveness, and peer social skills. And again, these are kids that have early intervention or mild school adjustment, introverted kids or kids who are just mildly acting out. In any event, you can see on the pre-post test results, and this teacher completes this after we do play intervention with the child with trained paraprofessionals in a play technique. It's not therapy. It's more to work on social skills. But the improvement in the domains that the teachers are rating after about 14 sessions, and these are about 20 to 30-minute play sessions. So I guess what I would say is that it's a very small intervention with a very large impact, and we had a very low repeater rate. I think we only had 24 kids who repeated over the 2,600 that we screened that needed anything. So we're very proud of the primary project program as an offshoot of school mental health. And so I guess I know I'm out of time, and I'm happy to answer any questions, or if you want to talk with me later about the DC school mental health program. So thank you.
This was a fantastic conference. I really had the opportunity to learn about a lot of policy-level organizations. Kind of at a political level, we met 2 Congress people. That was fantastic. I was able to kind of make the connection between the policy level of social work and take some of this away with me and bring it back to the clinical level when I'm working with my clients to help them better advocate for themselves and just better provide mental health services to the children that I work with.